there's a lot of buzz around CAR-T cells, and we've shown that we can achieve promising efficacy in a variety of different B-cell malignancies, in particular in ALL, in large B-cell lymphoma, and in chronic lymphocytic leukemia. But having said that, a majority of these patients will either not achieve a complete response or won't achieve a durable response. So there's a lot of efforts ongoing to try to improve outcomes of CAR-T cell therapy targeting CD19. But one potential approach is to retreat patients with a second CAR-T cell infusion to either deepen or reinduce a response in these patients. So we presented in poster form at the ASTCT meeting a preliminary analysis of 44 patients that were retreated at our center with another infusion, with a second infusion of CD19 CAR-T cells of defined composition. And in a nutshell, what we saw is that there was no significant increase in the toxicity of CAR-T cells, despite most patients, 82% of patients, receiving a higher dose of CAR-T cell the second time on. It's actually 1 log higher dose of CAR-T cells in 82% of patients. And the response rates were, so 20% of patients responded in the ALL group, 33% of patients in the CLL group, and 52% of patients in the NHL group. And the only durable responses that we saw that were more than 6 months were in the CLL and NHL patients, and specifically in patients who had received cyclophosphamide and fludarabine-based lymphodepletion prior to the first CAR-T cell infusion. So this really suggests that there's likely an anti-CAR immune response that is blunting the efficacy of second CAR-T cell infusions, and that potentially this immunogenicity can be reduced with the addition of fludarabine cyclophosphamide-based lymphodepletion. So that's a really important finding, and that's something now that has been widely used in the field, which is to use cyclophosphamide and fludarabine-based lymphodepletion. So this is another layer of data that is confirming that this regimen is probably the best at the time to date for patients receiving CAR-T cells. And the next steps will be to try to reduce immunogenicity by using fully human or humanized single chain variable fragments in the CAR. And there's a number of clinical trials currently that are investigating this approach.